Hello, everyone, and welcome to our September edition of our home health Q&As. And I found this picture today, and it hit me. I'm in Northeast Florida. I know you guys are located all over the country, and I wanted to share with everybody, happy fall, y'all. Y'all is a great inclusive term, and it makes me feel fun. It's fun for me to say it, although if you live in Florida like I do, fall means absolutely nothing. Cindy, are you?
Sherry? Maybe
Yes.
it's just me. I don't see anything.
Oh, you don't see this the shared.
Nope.
Okay, I'm going to go to it now. Thank you, Cindy. Okay, are we good? Everybody, you see that now, right?
Yep.
Okay, so that was my first faux pas of many that I will probably do today. But I wanted to give everybody the opportunity to think about fall. But in Florida, like I said, it means nothing. Cindy, are you experiencing any fall yet?
Well, I've learned in the last 5 years after moving south of the Mason-Dixon that I'm good with fall being upper 70s. I'll take that when versus triple digits with all the humidity. I see this as enough fall for me to be good at the moment, but it's definitely not the Midwest fall I grew up with where, 50s and 60s and sweaters and boots was pretty much, fashionable and fun to wear before the actual winter arrived.
I think the only thing that means fall in the South is a lack of humidity. The humidity drops a little bit, and we can actually dry a little bit of the perspiration. But I know that many of you guys are experiencing the dread that comes with fall in home health. And that dread means that you have to find coverage for some holidays that are coming up. And oftentimes that's quite the shell game. And with the way hiring is going right now, I think that that's significantly a shell game at this moment. And I'm showing my list of questions there briefly so that I can get them up on the screen. And Cindy, I'm ready to get started. Are you ready to get started?
Well, I'd like to make one more Southern fall comment there, Sherry. The pumpkin patches are lousy here. They're not pumpkin patches, they're just pumpkins somebody bought, drove somewhere and lined up in a parking lot or on a piece of grass. And I went to a corn maze my very first fall here, and I could not stop laughing. I mean, I know I'm unusually tall at 6'2", but the corn maze, the corn didn't even come up to my shoulders. I mean, it was like, I'm not lost at all. I can see everywhere from here. So it's just been an interesting adjustment. But those are elements that I think of with fall that just don't quite translate. But,
And
but I agree with you. I've always said you can tell how long you've been in home care when those first holiday commercials come on and your eye starts twitching. It's not,
exactly.
oh, it's coming. It's more like, oh no, it's coming. And now I got to figure out what I'm going to do.
It's coming, and most of us thinking about that in healthcare, we think about flu season. Flu season's coming, or it's here. So if you haven't, this is my public service announcement. If you haven't gotten your flu shot yet, please go out and get your flu shot. Okay, let's get started because we have a bunch of questions and they're kind of varied today. And I want to take a moment and remind folks to use the Q&A box and use the chat. And ask a question if something pops up or if something doesn't seem quite right or you're confused by how we answer it. Please let this be as interactive as possible. We got a bunch of folks on here, and we hope to make this entertaining so that we don't have you guys looking at your watch and going, are they done yet? That's always a goal of Cindy and mine, and so I hope that we can reach that goal today. So Cindy, you ready for the first one?
I'm ready.
All right, back to the old questions, the therapy questions. Can a therapist write PRN visit orders? Typically, we only have had skilled nursing write PRN orders for very specific medical conditions. Therapists are asking if they can write PRN visit orders for potential falls or additional therapy visits as required.
Well, there's a couple components in that question, so I want to break it apart. The first part is, can therapy write PRN orders? Absolutely. I have not understood why it's such a rare occurrence, and in many agencies it never happens. It's kind of reached this mythological level of only nurses write PRN orders and therapists can't. That is technically incorrect. The second part of that question, though, in terms of why nurses write them and what therapists are saying they want to use them for, is where we have to be careful. We know that regardless of the discipline doing it, PRN orders have to be very specific to the needs of the patient. They can never be written to accommodate scheduling issues or staff availability or nondescript. I've seen it kind of, well, can I just write a PRN visit for the therapy reassessment? Well, technically, no, because those rules talk about that the therapy reassessment is occurring as part of a regularly scheduled and planned therapy skilled care visit. So we really have to be careful here in terms of what are those reasons. The most clear example to me, Sherry, has always been about equipment and OT. So a piece of equipment has been ordered for this patient. We have a reasonable expectation, though I do believe with improved delivery services of late, it's probably a bit more specific than back in ye old days when it would get there when it got there. But if we're not sure when it's going to get there and we don't want to try to work around it or have them, we did our 2 visits this week and then the next day the thing shows up and we're not scheduled to come back for 4 or 5 days, we don't want them experimenting with the equipment and we don't really want them waiting for it either to start to be able to use it. So we can create a PRN visit related to teaching and training on this specific piece of medical equipment. We can utilize it. Let's say a patient has multiple caregivers and we know that there's been some turnover in that. And so if a new caregiver pops up into this rotation, we want to be able to train them timely. Again, they who knows when they might be there. They might be scheduled to be with this patient on a day our visit wasn't originally planned, so we can use a PRN visit to address that. So it really comes down to, it has to be very specific. And ultimately, if it's utilized, that visit it utilizes it has to speak to that specificity. So if I said it was for equipment, then I'm going to go make this PRN visit because the equipment arrived, and that's exactly what I'm going to say in my visit. I'm utilizing my PRN visit to address X, Y, or Z. So therapists who have not ever written them or not quite sure what to do here, we typically recommend that you spend some time with the nurses. And how are they writing them and what are the things that need to be present there? Yeah, some of the verbiage will be different between disciplines, but the concept is the issue. We just can't have them floating out there for nondescript reasons and then randomly show up in a week. We just went 3 times instead of twice and don't really say why. There's an accountability to that. That should never scare people off and say, oh my gosh, that's too many steps. Forget it. We're not doing it. I think there's a time and a place for them. They can cut down on trying to call the doctor at the last minute or trying to rework a schedule, or, oh my gosh, there's no visits left this week for what we needed to get done. So we strongly recommend them. And I know, Sherry, that's a bit of a longer answer than yes, you can go ahead. But I think the examples in that question, we just want to make sure that isn't the route people take, especially the additional therapy visits as required. That would never stand up under scrutiny with respect to a viable PRN visit order.
And I think it's also a great opportunity to review not just order writing, but verbal orders and how you want to not avoid verbal orders, but you want to make verbal orders something that are special because it's a customer service issue with your providers, right? And your referral partners. If you bomb them with 50, 5 to 10 verbal orders on every case that you see of theirs, you need to have those signed before you can drop your bill. And you don't want, the last thing you want to be hanging out is for a verbal order for 1 additional visit that you're not able to certify before you have to drop your bill. That's a place you don't want to be in as an agency owner or an agency operator. So, think about the customer service aspects of it and the ability to plan your care appropriately. And oftentimes PRN orders are a key part of that, especially in nursing. If we have nurses on the call, which I guarantee we do, I'm trying to think about what their life might be like if they didn't have the ability to write PRN orders. And I'm not even sure, Cindy, why it came to pass that therapy wasn't already part of the PRN orders.
I think it was, Sherry, we tend to, when we think about how therapists lay out that care plan, it tends to be pretty, I can't think of a better word right now, rigid. It's
Yes.
2 week 3, it's 3 week 4, 2 week 2. It's these numbers. And this idea that there needed to be some flexibility based on the presentation of the patient, first of all, there should be, because especially on complex patients with different needs that may fluctuate and different things I might have to accommodate, that makes sense. Also recognizing that even if I write them, that doesn't mean I have to use them. If the situation does not present itself, then that order just falls off when we're done and nobody needs to rewrite or fix or explain it away. But I think it was, everybody's writing 2 week 4, It didn't really express a need for some flexibility. So I think it went from they don't ever do it to they don't do it because they can't, to EMRs, even in some cases, not giving a PRN ability to writing orders for therapists and keeping that locked away with nursing. So I think it just kind of morphed from we never really acted like we needed them. So the assumption was made that they're just not relevant.
Right. Put in the corner, on a chair in the corner and told to be quiet. Okay. So second question is also therapy. I'm going to try and group these together by subject as much as I can today for you, Cindy. CMS requires a 30-day therapy reassessment. Can this reassessment be done using the OASIS M 1800 items embedded on every therapy revisit note instead of creating a separate 30-day reassessment form? Is the 30-day reassessment also required for maintenance therapy cases? And I want to, before Cindy answers this question, I think this is a great question because it is a focus of the reviewers right now. The therapy reassessment is a big focus and a big reason for additional documentation requests and in the TPE. So we want to make sure that everybody is paying attention to their 30-day reassessments for therapy because it has been a place where they're doing some denials. So Cindy, go ahead and answer this question.
Well, let's start from the end of it first. Is it required on maintenance patients? Absolutely, yes. Whether this is a restorative focus of care or maintenance focus of care is irrelevant. If it is considered skilled therapy, which it would have to be provided under the Medicare Part A home health benefit, then I am obligated to do a reassessment minimally every 30 days. Is there a specific form required by CMS? No, there has never been a specific form. They have never even required that you call the visit, you do it, anything in particular. Okay. Now you may say, what? Well, okay. Well, but from a tracking standpoint, we typically see agencies name the visit something, PT reassessment, OT reassessment, so that when scheduling it, we're able to keep track. We don't just lose track of it in the routine day-to-day activity. It helps us then be able to track, what is the gap since the last one, because we can identify that visit type in our system. Many agencies have come up with, or their EMR has given them a form. The form can be very helpful. Since this is a bit more candid in our Q&As, I think some of these forms are not helpful. It very often just repeats the initial evaluation, and that is not what CMS is looking for. So I think this is where some of the ambiguity around, if they would have just handed us a form, Sherry, and said, fill this out at least every 30 days, I think we would have done that. But the reason that they didn't is they want us focused on what is the purpose behind a therapy reassessment, as opposed to dictating a form that could cause issues or allowing it to be just repeat the initial evaluation, which is way overkill. The bottom line is the expectation is for the therapist to look at this patient, gather relevant objective and subjective information about what's going on with them at this point, look at their plan of care, and determine if we should continue, and if we should, how are we going to continue? So if I'm about to say that this original plan we laid out 3 weeks ago is working effectively, well, how do I know that? I can't just say, I'm Cindy Kraft and I said so. And that's not even how we come to that decision. We do, I believe, on autopilot, unfortunately, consider what the patient's saying to us. We're observing different things that they're capable of doing. And that helps us then say, oh, well, this is working and we're going to continue on the same path because this is effective, or this is not really working. And so I need to make adjustments to the plan of care, or, okay, we did better than we thought by this point. Again, my plan of care needs to reflect those kinds of adjustments based on the current presentation of the patient. So the essence has been, as Sherry just alluded to, what we're seeing denials over. So what we're seeing in particular is an affinity to deny the 30-day reassessment as not meeting the expectations, so that all therapy visits for that discipline in the second 30-day payment period are being denied over the problems in that reassessment. And you would think, since we've been dealing with the reassessment since 2011, this would be old hat by now. But I think some of those forms making us think we have to do a whole reevaluation and not really speak to that professional opinion is where we're messing this up big time. I have to be able to say why we're going to continue, and this is the objective and subjective information I got there with. So if I use specific tests and measures as part of the initial assessment, yes, that's why they say they want to see subsequent numbers. Because if that's what I quantified this with when we started, then logically I would want to administer those again to see where are we. And if I'm a maintenance focus here, then I would expect these results to be very similar to the very first ones, because then that shows we've stabilized function. So I would be using tests and measures regardless of improvement or maintenance, because I'm using that information to make the case we should continue. What do I ultimately see though? Oh, go ahead, Sherry.
No, finish. I'm sorry. I thought you were finished. Go ahead.
No, because I need to address one more point within that question. The issue being, I can't just put continue per POC, continue per position order. I mean, that opportunity to say, in my professional opinion, physical therapy should continue based on, here's my findings, here's what I'm saying, or I'm modifying the plan of care due to, or the patient has not progressed as anticipated, this is what we're going to change about it. That's what they're looking for from a skilled perspective. Two things. One, I think part of the problem we're having here is no different than the problem we often see on recertification. You cannot just take the plan that you made for 60 days, which apparently did not work, and just change the cert dates and expect them to just pay for 60 more days of home care. I mean, they're looking for, why are you going into another cert period? How do you know you need to? What measures, what concerns, what issues? We don't do the best job in many cases of teeing that up. The reassessment makes it even more focused, but it's the same issue. So back to one element in that question before I turn it over to you, Sherry, is I'm not sure why the M1800s would ever be integrated into every visit for therapy. That is not the intent of those items. Those items are there to be measured at certain time points. I'm not sure why they would ever be included on every visit, and they would absolutely not stand alone as a therapy reassessment. Those are discipline neutral data collection elements within the OASIS tool. They do not correlate to therapy decision making, any tests and measures, anything quantifiable. I mean, the ambulation question just basically says, do you need intermittent or continuous at least supervision? Same thing for bathing. Those would never, ever work. So I usually try to, maybe sort of kind of polite in this context, Sherry, I'm saying, no, those would not do it. And the form isn't really the issue. It is, am I presenting updated subjective and objective information and my analysis to justify continuing the plan?
And that brings me to my next slide here, because I wanted to share with everyone that we have a new product. And that product is defensible documentation. And what I want to say is, we read documentation every day. We read every discipline in home health. We read every type of OASIS that can be done. And the thing that we see most often is a lot of writing, but not getting to the point. And so one of the reasons that we put this program together was to say it's not that hard. We've made it more complicated than it should be. It needs to have a flow. It needs to tell the story. But oftentimes we get bogged down by clickitis in our EMR and hitting every box and then having to answer every box. And we put ourselves behind the 8 ball when it needs to be very succinct writing and very succinct information that you're gathering when you're on a patient visit. And many times, Cindy, the science is not in the note. The reason why you became a therapist or a nurse is not conveyed. You sound like you're trying to tell somebody something in a preschool or a sub high school level, when you should be leaning into the certifications and the license that you have and using the science and using the collection of evidence-based care to demonstrate why that patient still needs to be receiving that in the home. And Cindy, I want to go over a couple points about the reassessment real quick before we move on from that, and just reiterate, a therapy reassessment does or does not have to be done by each therapist that's in the home.
Yes,
PT to your speech.
Yes, I mean, they each have to do their own. There is no crossover. And if you think about the intent, I am not in a position as a PT to justify why somebody needs OT. I'm not an OT any more than I'd be in a position to justify effectively why someone needs nursing. Each discipline has to do that themselves.
And Cindy and I both believe that the therapy reassessment is a little bit of a vestigial leftover from the point in time when we were doing counting visits and having thresholds. However, it is still a requirement, and it's required by every discipline. And does it have to be done exactly on the 30th day, Cindy?
That's usually a very risky situation, because if we're going to cut it to the very last possible minute and we have the patient cancel or something happen, then we're going to get out of compliance pretty quickly. I think that what we have to look at is there's no 5-day window on this. It says minimally every 30 days. So if I go out and I assess my patient and I'm like, okay, so 2 weeks in, this is not going the way I had planned, I absolutely can do a reassessment right then, which is not, oh, fill out the, no, what do I need to change about my plan? And why do I need to change it?
Mm-hmm.
I immediately reset the clock for the next 30 days. So if I do it 2 weeks in and I do it today, well, then I have 30 days until the next one's required at the high end. But anytime throughout this, and this is also where, particularly if we're utilizing therapy assistants, excuse me, waiting to the last minute can be problematic. If I have a PTA who's seeing the plan day to day kind of coming off the rails, I don't want them waiting to day 28 to have me come out here and take a look at this. If something is going on, then let me know and let's schedule it sooner so that we can have the most effective care plan. And to your point, Sherry, yeah, I do think it's residual from when the therapy visits directly affected reimbursement. But bottom line, any of us, including the nursing discipline, if someone says, why do you need to continue with this patient, should be able to answer that question. And if I really don't know, or if it's because it's on my schedule, because we have an order, because she cries if we talk about discharge, then we are in a dangerous area of this may not be actual skilled care.
Exactly. And that's something that we definitely do not want to have on our conscience when it comes to recertifying a patient for that second 30 days. I hate saying recertifying because that implies the 60th day. But when we reevaluate whether they need to go into that second 30 days, which appears to be a focus of the review folks, what they're looking at more the second 30 versus the initial 30, those 30-day assessments are crucial in making that plan, making that case to going into that second 30 days, correct?
Yep.
And I apologize, you guys. My phone started yakking at me, and it interrupted us. And I super apologize for that. I'm not sure how that happened since the volume is completely turned off, and it's totally turned off. Anyway, second thing I want to say is when you complete that 30-day assessment, if you were to get a review from CMS or from one of the reviewing authorities about the second 30 days, is it prudent to include the therapy reassessments that may have occurred in the first 30 days in the documentation that you send in to the reviewer, Cindy?
You know, it's always been a longstanding thing when it comes to things like ADRs is to send them only what they ask for, because we don't want to embellish and potentially open up other cans of worms. And I understand that, but you know, looking at these denials and arguing that the second 30 days, the therapy was not skilled, reasonable, and necessary without them ever seeing the reassessment because it's in the previous 30, I would strongly consider including it. I've had people say, well, then should we do it again first thing in the next 30? Oh my gosh, no. Why drive ourselves insane and have the therapists all rise up over this? I just think it's prudent. If we're concerned that they may, you know, they're only looking at the second 30, then how well did we tee that up with the reassessment preceding it? And if it's in the previous 30, I would include it.
I would too. So thank you. So everybody who gets an ADR, if you get a request for documentation and it only includes the second 30 days of care you're providing, Cindy Kraft and Sherry T are recommending that you send any pertinent therapy reassessments if they're continuing to have therapy visits in that second 30 days. Consider it an initial eval for the second 30 days. Send it in with that paperwork to CMS. Cindy, you had something else?
No, the only thing I would say is I'd also periodically do some random sampling of your therapy reassessments if you haven't been doing so already. Because if you're preparing for an ADR and you look at it and go, maybe you wouldn't send it. And maybe it's something that if all this basically says is continue because I said so, yeah, there might be some work to do about that content.
And we have a question about this from a listener here. Can you give guidance regarding a missed 30-day therapy eval? Which visits would be considered non-billable? Would it be any visits after 30 days that are not performed by a qualified therapist until it's completed, or would it you consider making the most recent visit prior to day 30 non-billable?
Well, the issue comes down to the guidance we've always had, which is way back to when some of us may have PTSD still, when it was, numbers of visits and it was the compilation of all three therapies, and that was a disaster. But the guidance from that point onward has been, once it has been missed, it is the visits that occur after that that are not reassessments, that are non-billable until that reassessment gets done. So if I did it, it was supposed to be on day 28 and we lost track of it, and an OTA went instead of the OT, and now we're at day 32 and wait a minute, somebody didn't go. It's what's past that 30-day expectation. They don't preemptively punish you and say, you should have gone out there sooner. But once we cross 30, it's the gap until someone gets out there and does it.
100%.
I just want to encourage, a big contributor to that early on, and in some agencies today, is cutting it so close. Because I think some of this, and again, if we suggested, well, if you made it every 3 weeks, you wouldn't have to worry. Don't focus on it from a filling out a form workload issue. If I'm in a state that has more frequent supervisory visits, let's pick my previous home state of Illinois, every 6th visit. If I incorporated elements of the reassessment about why are we going to continue, what am I basing that on, which should be part of a supervisory visit anyway, a well-written supervisory visit could constitute a therapy reassessment concurrently. So I could be continuously compliant, just doing this as part of my supervisory visit, and never have to worry about, did we ever get near 30 days to do it?
When you're doing this, Cindy, is evaluation day 0 or day 1?
To be consistent, it seems anytime we approach CMS with that this is day 0 is when we start. So I would apply the same thing here.
100%. And I want to reiterate that if you have a CODA or a PTA, there is a supervisory requirement in a lot of states that precedes that 30 days. So paying attention to that is super, super important. And the content is super important. So your aide or your assistants, should be actually gathering data to assist with the decisions that your 4-year license is going to make when they do those reassessments. So it is a team effort, and it should not be an entirely brand new evaluation. It should be focused on what needs to be changed to get that patient to goals or to get them back to the function that is appropriate for them.
Sherry, well, before you do, because there's a lot of elements, I think people may say, oh my gosh, they spent like the first half talking about one thing, but it's a thing that hits multiple elements. And it goes beyond therapy in terms of answering the question. And it's not unreasonable for the payer to ask, why are you seeing this person? That's not a mean question. That's a fair question. They're about to cut the check. If you were going to cut the check, you'd want to know too. So maybe some of the timing issues feel onerous, or maybe some of we have to, redo an evaluation have complicated this, but it, much like the title you have up, Sherry, it isn't that complicated. But I want to touch one more thing on what you just said, Sherry, because it made me think about the utilization of PTAs and OTAs in this situation. There has to be some degree of harmony between those visits leading up to the reassessment and what you put on that reassessment. When we look at a record as a whole, and you have a PTA that's clearly been following the plan, meeting expectations, clearly has been communicating with the PT that we're nearing ready to discharge, and then this random PT shows up, does a reassessment, and says, we're going another 30 days for the same old goals, it didn't change a thing, you're really setting yourself up for someone to go on Team PTA and deny this thing. Because it just looks like, who wandered in here and just dropped, we're going to continue, when everything looked coordinated to go one way. Now, something could have gone sideways on that visit, but again, why are you continuing? What did you base it on? What are the subjective and objective elements? But a lot of times, Sherry, it just looks like they didn't even read the preceding stuff and just said continue.
Yep. And it's super important that story be told and it's consistent. It doesn't have to be the same therapist, Cindy. It just has to be, that interdisciplinary care that they're looking for the efficiency. Cindy, here comes a goodie, but an oldie. And this one, again, staying on the therapy theme for the first 30 minutes today. And a reminder.
We got a lot of those emailed in this time, didn't we?
Yeah, we did. So anybody who has any questions, again, you use the Q&A box, use the chat. Thank you guys for sending in a couple questions that we just answered. And if you want to reach our documentation, there is a great podcast. And I say Cindy and I did it, so it's kind of like a humble brag, if you will, Cindy. It's gone home health viral in that it's been seen by over 2,000 people at this point, and it's a podcast that's attached to this product that it's real talk about what documentation should look like. And if you have any questions, reach out to us via our contact app, and we can handle any questions that come from that. But we're trying to get to the essence of what your clinicians need to write, so that when it comes audit time, you're not having to hustle to try and make something that should have been done in the first place. And so it's more about looking at the efficiency and writing to the case in an appropriate manner. So Cindy, can a therapist do a home health aide supervision during their visit, even if nursing is also seeing the patient? Or does the RN have to do the supervision unless it's a therapy only case?
The nursing have to is still a lingering piece of old information. The conditions of participation, which were updated several years ago, highlighted that the supervision of the aide needs to be done by somebody who is knowledgeable about the patient and the aide plan of care. It does not delineate a specific discipline is the one who has to do this, or that the therapist can only do it in a therapy only. I hate that term, Sherry. It just sounds like we've locked everybody else out, and that's not the case. But yeah, if you think about it, I've thought for years, if we have this patient particularly receiving occupational therapy, why would you not have them embedded in the supervision process, as well as making sure that that plan of care for the aide is as current as possible, and not having the OT talk about this patient is doing so much better and discharging them able to do X, Y, and Z with an aide care plan that continues doing that for them, and the aide will continue to do that for them because they have to follow the plan. So this is a much shorter answer. Yes, they can. And we really need to think about, because I think the who knows more about what's going on with this patient is how we decide who really needs to be doing the supervision.
So that was pretty straightforward, guys. Yes, they can. And again, adjusting the plan of care and just adjusting the aid care plan and all those kinds of things can be done by the discipline that's going to be supervising them going forward, particularly if you have OT involved. The things that surround bathing are often considered an OT skill, but having them do that appropriately and on time, again, at least every 14 days, right, Cindy? If you do it early, then it resets the clock to go again on the 14 days. Now let's switch our hats a little bit. We're heading to Oasis land. And Cindy is happy to see that because that's her favorite subject. In 1700, Cindy, if a patient is alert but not fully oriented to time, let's say they get one or more of the C0300 questions wrong, would the correct in 1700 answer be O2? Or because the patient is alert and O3 states is not alert and oriented, O2 says nothing about orientation?
So some folks that may not be as familiar as sleeping with the manual under my pillow may be a bit confused just by those numbers. So I want to be sensitive to how I try to answer this. First of all, there is no direct correlation between BIMS results and how we score item 1700 with respect to their cognitive functioning. What do I mean by that? There is no response to one that means it's always this response in another one, okay? I'm always very careful because sometimes people cross that line that say, well, if it's this, it's that over here. Or my scrubber said, if it's this, it's that over there. I only believe those if the guidance manual flat out says these two things go together. And in this case, they don't. Okay, so in terms of any sort of joined at the hip official correlation, it does not exist. Clinically, does it make sense to have that conversation and to think about the relationship between those two? Absolutely. So the inclusion of the BIMS in OASIS E has made us do a formal test and measure now with respect to this. And it can be very eye-opening about this patient's ability to complete these tasks. However, it is not completely comprehensive. If you think about recalling 3 words, they only have to remember them for a matter of a few minutes. And a patient could be very successful at that, but if I asked them 20 minutes later what those 3 words were, they have no idea, which is going to make me wonder about what happens when I teach them about their medications or their function. As far as what constitutes response 0, Well, we have to think about in 1700, to be a 0, I'm saying my patient is alert and oriented, able to focus and shift attention and recall task directions independently. It's a comprehensive thing. And so I have to look at this and say, is my patient capable of managing all of this? I commend the question because I think far too often our patients are being marked 0 because they are alert and oriented, and we only read that far. Because when I choose a response 0, I've communicated to CMS that this patient is alert and oriented, able to focus and shift attention and recall task directions independently. So whatever task directions I'm about to provide, these people are on it. So if I'm now writing a plan that says, yeah, maybe not so much, I'm going to have to repeat a few things, then we need to consider other responses. The issue of response 1 versus response 2 is response 1 talks about the patients having some issues related to those things in new or complex situations. So these can be patients that start to fray around the edge a bit in some of these areas because of the chaos currently going on in their home, or the newness of receiving home health, or the daughters moved in and they normally don't live there. So that this patient has to have information repeated or cues provided only under these complex or stressful situations. Again, we're not saying that they are, completely none of the things in a 0, but we've noticed that for some of that, at least, they need to have some sort of reminder or cueing, but it's really under those stressful or unfamiliar conditions. When you're looking at a 2, then we're saying this is really where the environment has to be managed a bit differently. That we have to minimize distractions and minimize competing issues to be successful with that. So I wouldn't get hung up on alert and oriented is in a 0. And if they're not, that means they're down way here because it says they're not alert and oriented. I wouldn't fixate on that. I would look at the comprehensiveness of that response, because if you ask any speech language pathologists what they think of this assessment question, they basically tell you it's garbage, because those tasks do not all go into one thing. Being alert and oriented, focusing, shifting attention, recall, my gosh, that's not all one sentence in terms of a patient's ability. So this is really a discipline neutral data. Give us a general idea how this patient's doing. And back to if there were struggles on the BIMS and I'm questioning some of this, then it really comes down to, do I think that this is really about being in a stressful or unfamiliar situation? Then I would lean to a 1. If this is really more than that, and I'm going to need to look at, how the environment is distractible and that kind of thing, then I would lean to a 2.
Okay. Cindy, I think you killed that one. Another OASIS question, 1850. What is considered to be unable to transfer self? If a patient needs max assist for transfers, could that not be considered unable to transfer self? Or do they have to be fully dependent, GG transfer items answered as 0 1s, for 1850 to be marked a 3? If the patient requires 2 helpers to transfer, is response 3 appropriate?
Okay. What I hear, and I want to make sure we're clear about this with respect to the OASIS assessment of function, is that unable to transfer self is not necessarily synonymous with catastrophically immobile. Okay? Because if you think about this, the other elements of 1850, that if a person needs a piece of equipment and at least human supervision, so the infamous someone or something, they are not scored as a 1, because a 1 says one or the other. If they need equipment and minimal human involvement concurrently, they are not a 1, they're a 2. And that starts unable to transfer self. And this is where, no matter whether I'm teaching it or we're using our OASIS knowledge assessment product with scenario-based testing, anytime I put this question out there, clinicians get it wrong way more often than they should, because we get stuck on the unable to transfer self and we immediately assume this means a higher level of impairment. But if we think about it as discipline neutral data collection, if they need a piece of equipment and they need a person, they are not transferring themselves. So someone doing this transfer with a cane and me supervising is not transferring by themselves. So we got to be very careful when we start talking about unable to transfer self is totally dependent, 2 people, all this other. It could be, but don't go down that path with respect to how we're going to try to put layers to unable transfer self that this question does not have. When we look at the difference then between a 2 and a 3, who really ends up a 3, has to do more with the ability to bear weight and pivot. Okay, so because 2 and 3 both have them unable to transfer themselves. So the issue is about bearing weight and pivoting. So the most clear example of a 3 is a Hoyer lift, or if they're being totally lifted out of the bed by people. Okay, the person is not bearing weight, they're not doing the pivot part, they're being physically moved from the bed to the chair and back. That's what we're talking about with a 3. So the inability to transfer self, again, someone has a cane and supervision is going to be a 2. And if someone is able to get from the bed to the chair with 2 people, but they are bearing weight and they are participating in the pivot, they would also be a 2. So we have to make sure we're looking at it comprehensively. The other issue is we have to be very careful correlating this to the dependent response in GG. Because I think people are pretty good at understanding what they believe dependent to mean. But dependent in GG has a but to it, which is if it takes 2 people to complete the task, they are supposed to be scored dependent. And that could be someone is physically helping them and the second person is supervising and may not even touch them. If 2 people were necessary to complete this task safely in a GG, that's what dependent means. So we may envision dependent, again, as hugely impaired and all kinds of lifting and torquing. That's possible. But this could be an individual who's transferring, we'll use that as an example, with someone who's physically assisting them, maybe moderate assist to transfer, and a second person who's a spotter. They would be scored as dependent. That kind of scenario, Sherry, is also what's getting currently a lot of incorrect responses on our OASIS knowledge assessment, because I don't believe people have really thought through how OASIS defines dependent in the GGs may not align with what I'm trying to envision in my head clinically and can interfere with an accurate result.
And that brought up another question, Cindy. There's a question about 1840 that the listener has read some literature that if a patient does not have a commode, we can code them a 2 if they are unable to get to the actual bathroom. Is that true?
But a 2 is a response that says there's a bedside commode.
Right.
So you're saying that they don't have one, but I can score them that anyway?
Well, if they don't have it, but they're still unable to get to the restroom.
Okay, the toileting one has always been kind of weird because those response options don't seem to flow like the other questions. So we have the, you're perfectly wonderful. You can get 2 from, on, off. It's glorious. That's how you're a 0. You got to do all of it. If you have a problem with one of those 4 components, 0's off the table. 1 gives us a very general, assisted, reminded, supervised. Okay, so if I need anybody doing anything for any element of that, I'm at a 1. Then our next 2 responses start talking about equipment. We're dealing with bedside commodes, we're dealing with urinals and bedpans, where we have to really think about, that's what they're asking you. Does this patient utilize a bedside commode? Does this patient utilize a bedside, a urinal or bedpan? So when we review this on our outsource side, we'll see that marked as, needs a bedside commode, and there's no mention anywhere in the documentation. It does not have it under equipment. It does not say it was recommended. It does not say it was ordered. It does not say it was recommended and declined. It says absolutely nothing. Well, we're going to put that down as an OASIS recommendation for the clinician to revisit this, because there isn't documentation explaining your answer at all. And the expectation around a 2 is there's something going on with the bedside commode. Now, if I have a person who does not have a bedside commode, does not want a bedside commode, so they're not there, and I'm under no obligation. Even if I ordered one and they agreed, well, it's not here. I haven't seen them do it. The guidance tells us I don't have to pick the bedside commode response. If I believe they are really, really unsafe and cannot access the bathroom, then I can use the dependent response. I can go all the way down to the lowest response. But again, my documentation has to be clear. as to why I have these safety concerns and what's going on with this. Because on one end, I see these bedside commode responses picked and no documentation or little to explain this. Or I've seen a trend in some agencies where apparently nobody can get to the toilet now and everybody's a 4. Okay, wait a minute. No, because if I'm going forward, then my documentation is absolutely going to have to support why this is, what my concerns are. And when I see 4s in toileting and yet 3s in ambulation and 2s in transfers, wait a minute, you suddenly lost all ability to get anywhere near a bathroom? I'm not believing that this 4 is completely accurate unless you can explain it for me. So we have to be sensitive to the equipment piece. The devil's in the detail when it comes to the documentation. But if we're saying that they do not have this equipment, they're not going to get this equipment, or it's en route, but I'm not even sure it's going to work, and they are way unsafe accessing the bathroom, then 4 would be the correct response, not the bedside commode.
And if you guys have any other questions
In
about,
case I got the number wrong, because it is a little later in the day, the dependent. The most dependent response, because I'm thinking, wait a minute, is 4 bedpan urinal? I don't want people thinking she just said make them all urinals. No. Significant safety concerns that you can spell out, you can use that dependent and toileting answer.
and I want to bring your attention to the fact that Cindy just made an error potentially on Oasis. And so this is a special moment that probably should be etched in
I'm
stone.
just clarifying because I'm not sure, and I would hate for somebody to come back and say, Cindy Kraft said if you don't have a urinal, everybody's got if you don't have a bedside commode, everybody uses a urinal. Because that, no, I don't want to be responsible for that.
You know I'm teasing you because you could just reach underneath your pillow and grab it right now, grab the manual right now and clarify it for everyone.
Yeah, it's PDF'd on my screen, Sherry. It's always accessible.
If you guys have any additional questions about Oasis items, Cindy, we'll be giving everybody our email addresses at the end. Please reach out to us. Right now, I want to go to a back office question, Cindy. And remind everybody that if they are interested in looking at more information on our defensible documentation, you can scan the QR code that's on the screen and it'll take you directly to it and it'll give you access to the podcast as well. If you're interested in free information from K&K about home health, we have a really thriving YouTube channel, and that YouTube channel is where we house all of our free content. So you'll see unfiltered podcasts, older webinars that we did back in 2016 that are still relevant about medication management and therapists, about goal writing. There's some really good content on there. You can scan this QR code and subscribe to our YouTube channel, which is also where we house our Q&A. So we've done, this is I think our 8th Q&A, Cindy. Can you believe that? It's a 6th or 8th, and I'm not sure which one, but I'll have to get back. But they're all on the YouTube channel as well for access for future time if you need them. Okay, question number, I think we're on number 7. Looking at workload expectations for a quality review nurse. This would include coding and plan of care review along with review of all OASIS, start of care, resumption of care, restart, transfer, discharge. Would 7 to 8 per day, including all of that, or just 7 to 8 starts of care per day be appropriate?
Well, Sherry, I'm going to tee that up and then I'm going to turn that over to you. I think the challenge, because we get this question quite often in terms of how many can get done in a day. And people will ask us, particularly because we do outsource coding and OASIS review. So it's like, well, you should know how many somebody can do in a day. I think the challenge is to first figure out what else is this person expected to do in a day. Mm-hmm. The big difference between many folks that we work with that use internal people is that person is not just doing heads down coding and OASIS review that day. They're answering the phone. They got to cover if a manager's gone. They're answering questions from the staff. They're going to a staff meeting. They're trying to build educational content. They're trying to do this other thing. They're called to 3 different meetings. So I think, if there's a lot of that competing time, first we have to figure out how much time of their actual day is allocated to this work, and then figure out how many you can do. I mean, would you say that's fair, Sherry? Because our folks, that's all they do. They get this, they sit down, they do it. So what they can do in a day can be very different than somebody's that's wearing 3 hats and trying to cover the front desk while somebody goes to get lunch. I
think that's the biggest thing, but you also have to take into consideration the EMR, the quality of the documentation that they're receiving from your intake personnel, the quality of the documentation that they're receiving from the clinical personnel, how much codependency is occurring between your review nurse and your clinical staff. And by codependency, I mean, has your clinical staff just said, I give up, and allow the review nurse to start filling out their documentation for them? Those of you that are on this call, you may not have experienced that, but we see that every single day. That we have reviews that come into our purview, and they literally have answers that are left blank. And we oftentimes will turn those back over to the agencies that we work with, and say they need to be completed by the clinical staff prior to the review. All these things kind of play in, and I think Cindy hit the nail on the head. In agencies where we're having difficulty hiring, I want to be very clear. The question asked about a review, quote unquote, nurse. I think nurses are great reviewers, never have a problem with reviewing with nurses, but there is a shortage of those nursey type people. And it would behoove every agency to look at other folks that could be in their review department that may have more availability in hiring, and more skill or different skills to diversify your review group. But it's real tough to say, not knowing EMRs, not knowing all those other factors that Cindy mentioned, and the quality of the documentation that's occurring on the front line, how many would be appropriate a day. I would be very uncomfortable.
And Sherry, looking at the question again, I mean, you're talking about, if I'm reading this correctly, so that one individual is tasked with coding it, reviewing the OASIS, and dealing with the plan of care.
Yeah.
Like you said, that can be a bear depending on the EMR and the intake information. I think 7 or 8, if that's all they did all day, could be possible. I think those 3 combined, and potentially other things that have to be done. We also have to factor in how much back and forth is there with the clinician. And I think, to what you said, Sherry, not only do we unearth situations where the clinician kind of leaves things blank, we also find reviewers that when we ask, do you track and trend errors? And they go, for what? Well, I know many reviewers, and they know who their problem children are. You don't even have to ask. They immediately pop into their head. The people that make the same mistakes with the same corrections in the same process over and over, that's not an effective use of anybody's time.
Mhm.
I mean, not only have they given up at times and not put anything in there, we encounter clinicians and agencies will say, my staff are wonderful. They never argue about the corrections. Okay, do they keep making the same mistakes? Because not arguing and yet repeating the mistake just means that they've become dependent on your reviewer to fix it, and I just agree. And then I go out and do the next one and mess it all up, and then you fix it and I just agree. And now they can't do 7 or 8 because it's the same mistakes over and over and over. I mean, coding, as you told me, Sherry, if you got the right information, can be fairly quick. If it's a very complicated situation, can be significantly longer. Plans of care can vary greatly depending on the complexity of the patient. Personally, OASIS is the most stable of the 3. It's the same questions every time. And other than when we went through the big change to E, we don't have an OASIS of the month club. So clinicians should make less mistakes over time, period. If they understand the guidance, if they utilize the guidance, I should not be correcting your functional assessment day in, day out for all eternity, because that takes up a lot of time that I think causes problems here. And far too often, as we work with agencies, they don't track and trend it. They don't really, I'm helping it. Their nurses are so busy. It's just easier if I fix it. Well, now you have somebody doing double and triple work and costing you and them.
Exactly. Another OASIS question, Cindy, and then we need to let everyone know of something that's come to our attention so that you can prepare for something that's on OIG's plate right now and what they're looking at.
Okay.
This one is, if in the event of a telephone DC, the visit cannot be made, is it acceptable to answer C1310A, acute onset of mental status change, if there's evidence of an acute change in mental status from the patient's baseline 0, no, or has there been evidence in the last visit that was made, or should the appropriate answer be not assessed, no information?
There is not a hard and fast. I mean, the hard and fast is we really, really, really got to make this discharge with no visit an anomaly. I think some of it is a scripting issue to make sure that, oh, I don't really want to. Okay, good, because I'm so busy, I don't want to go anyway. We got to minimize those. We can use information that's present in the record. So I would argue if you can find substantial information within the appropriate time frame in actual documentation to address that question, you can, and I would note where you got it from. But if you go back through there and you can't really find anything, then it truly was not assessed.
Okay. I think that answers that question. Obviously, it's best always to make the visit when you can, those discharge visits. However, telemedicine and telehealth, it provides us some opportunities in the event to get better information anyway, right, Cindy, than what we get if we did no visit and no call. So we need to do as much as best we can to get in front of the patient, and at the very least in contact with the patient. Now, Cindy, we wanted to take a moment at the end of our session today to let folks know about something that we learned this week from about what's going on at the OIG. Can you share with our listeners?
Well, I could go on a whole tangent, Sherry, you know that, which is why we're working on an unfiltered production specifically to this, but we wanted to touch on it here briefly in case anyone has missed it. A report was recently released by the OIG. They were investigating the issue of how well home health agencies are doing at reporting falls with major injury. So what they did is they looked at claims data, patients that were hospitalized with subdural hematomas, fractures, significant injuries related to falls, and determined of those which are home health patients, that were actively home health patients before they were transferred to the hospital, and then went and looked for OASIS data, because we know on a transfer, there is a specific OASIS item indicating if the patient has fallen. And if they did, one category is a major injury. So thankfully they didn't pick the interrupted fall or the other stuff that's harder to track. You think we would notice if somebody got a subdural hematoma or broke a bone. Well, what they found was that the accuracy rate of reporting these falls by home health agencies was barely over 50%. They went on to analyze this data and determined that there was more underreporting of major falls in agencies with higher star ratings. They used an example, they didn't name them, but they said an agency in Florida who has 5 stars on Care Compare had not reported a single one of the 15 or 18 falls that they found in the claims data. So what I want to say here, Sherry, is that one, if you have not heard of this report or seen this report, I believe we can connect the link here somewhere, Sherry, to make that available to look at. But to me, it's another example of the finessing they're able to do with data and why we cannot ever use OASIS data in ways other than reporting every item, every time, completely accurately. Any of this kind of, I can make them look worse, nobody can get to the toilet now, everybody's dependent in everything because that's going to improve my outcome score. Yeah, these things are becoming more and more obvious as they analyze our data. And the more they think we manipulate it, the less they trust us. So that's why we see so many things moving to claims data. And I know somebody's going to say, how do you know the claims data is right? Maybe the hospital put it on there wrong. I'd buy that if it was maybe 20 or 30%. But to be 50% and agencies not reporting a single one when they clearly had patients hospitalized while they were home health patients due to falls with major injuries does not look good. And in my conversations with several folks about this, there's no good way to spin this. I don't know how we try to say, oops, I mean, it was a data error or it was a this error or it was something else. So I just want to reiterate, this is why, and K&K has been doing this for 10 years, I have for more than 2 decades, we have to make sure it's accurate every time. And that we're following the guidance whether we like it or not, or agree with it or not. But any, let's just go a little worse. Let's just, I don't really want to report that because, two-way communication with the physician is hard. So I'll say there's no issues, or yeah, we got two-way communication, even though there's no evidence that occurred. They're paying attention. And so we just want folks to not take those chances because this does not look good for our industry.
And I think it's going to lift the box or lift the lid off of Pandora's box potentially. If they start if they start doing reviews and sending out additional documentation requests based on the data differences, it's going to be an interesting time in home health. They're really going to be able to get to the folks that may be manipulating some of their data that's being sent in, and that should give everybody a little bit of pause, because that's what we hope to happen. Cindy and I personally do, because I think it's very difficult for some agencies to compete with folks that are manipulating their data, and it's really important that we have that opportunity when we find out this information, that we share it with you guys. So thank you for.
I just want to add real quick, because there were several recommendations from the OIG. Many believe that where we're going to see this first is it getting integrated into the survey process of looking at falls with major injury against claims data. So basically coming in with, there's been this many hospitalized, looking at it against our OASIS accuracy. Because OASIS accuracy has been stressed at the beginning of that guidance manual forever. And OIG was basically saying to CMS, it's time you enforce it.
Exactly. And that's the thing. It is absolutely time to enforce it. So I put up the slide that has our contact information, and Cindy, I wanted to share with everyone, any of our value beyond the visit, all of that goes to our new website, but our new website direct address is K&K Health. A lot of folks refer to us as K&K, so we just leaned into it. And so if you go to kandkhealth.com, you can find information on a lot of different things, and definitely reach out to us if you have any further questions. I had a couple folks mention that they wanted the specific reg that says that therapists can do the aid supervision if the nurse is still in there. And I think that we have that regulation, but I do believe, Cindy, as we end, that it is one of those regulations that is true because it doesn't say we can't. Not that it says we can.
It's in the conditions of participation under aid supervision.
Aid supervision, conditions of supervision, or conditions of participation. That's where you can find it, folks. But if you have any further questions, please reach out to us via email, and we'll answer you right away. And I just can't thank you enough for being here today. And Cindy, do you have any final thoughts before we end?
Nope. I've always find these to be interesting, and questions lead to other questions. And I appreciate people setting them in, and get your questions ready for our next round.
And I'll be sending out the recording as soon as we get it developed, and look forward to it. And we'll see you in a couple months. For the last one this year is going to be on November 30th at 1 o'clock, which is the week after Thanksgiving. And everybody should be kind of turkey drunk at that point. So with no further ado, I wish everybody a great day, and be safe out there.